All right, so by the time we get to eye and ear, disaster and emergency nursing, we're basically feeling pretty good. We're excited. We're knowing that we've been here, we fought a good fight, and we're continuing to fight a good fight. We can see the light at the end of the tunnel, right? We're being optimistic regardless of what our circumstances are looking like, because it's never over. You just give it your best, and you just continue fighting the good fight, right? So for this semester, emergency and disaster management obviously takes on a whole new meaning because we have COVID-19 happening right now. And so this is really going to resonate with you guys. And actually, I think it's going to help you understand the content a lot better. The last time I taught this, when it really kind of resonated with my students, was when we had Hurricane Sandy. So the main thing right off the bat is I want you to be able to differentiate between emergency nursing versus disaster management. What is the role of the nurse in emergency nursing? What is the role of the nurse in disaster management? Does the role of the nurse change in emergency nursing? Does it change in disaster management, or is it just the same all the time? Like, is there a difference that happens at any point? So remember, we have our code of ethics, we have our nursing practice. We're supposed to be practicing within certain rights and within certain skills, and we're not supposed to be going outside our boundaries. But now, if a disaster is going on, are there certain things that are going to be a little bit different, or are we going to be allowed to do certain things that we weren't allowed to do before? So right off the top of the bat, guys, know the difference between emergency nursing versus disaster management. And then as we're talking, specifically under disaster management, we're going to talk about triage a lot. Like, how do we triage a patient? How do we decide which category they're going to be in? For your purposes, I've highlighted the charts that you need to look at in your book. And the triage one is in table 73-1. Right. And so when the nurse is working in triage, they're the ones that initially assess the patient, and they determine which category your patient is going to be in. So the patient can either be listed as a priority patient, or not so much, meaning that they think that the patient is going to die, right? So they can either use numbers from like 1 through 4, or they can use the color-coded system from red through black. So we'll talk about this later on, and there is, like I mentioned already, a chart in your book that I definitely want you to look at, because you have to be able to tell me at the very least, what does a patient who's a priority category 1 look like versus what does a patient who is priority category 4 or the black category look like, you know. So at the very least, I want you to know the difference between 1 and 4, or red and black, because the in-between can be a little bit tricky. All right. And then we'll also talk about some of the different things that we've created over the years that we're trying to kill each other with, like for mass casualty and terrorism types of things. So we'll get into that as well. So we have a whole bunch of different learning objectives here, and I think these are pretty much coming directly from your book, actually. So we're talking about priority emergency measures. We're talking about the components of an emergency operations plan. So that is important as well. We'll talk about the EOP, and every institution must have some type of emergency operations plan, right? This is where JCAHO comes in. So they have drills, and pretty much everybody has to know what the plan is. We'll talk about triaging, we mentioned. We're talking about the different levels of personal protection and decontamination procedures that may be necessary during an event. So now PPE is a big deal, right? Because everybody is trying to get some. So we'll talk about some of the physical injuries that can happen after blast events, talk about isolation precautions that are necessary for bioterrorism agents. We'll talk about the various chemical agents used in terrorist events, the effect and decontamination and treatment procedures that are necessary. And we'll talk about radiation near the end. And the whole time we're focusing on the nursing process, obviously. And for nursing 411, the key is always about interpreting data and then prioritizing nursing care. So this is the chart or the slide that has all the different charts and tables that I would like you to look at. So specifically for this for these two chapters, 72 and 73, you honestly don't have to read the book. You can just listen to this audio and then look at the charts to kind of get a really good understanding. Because really the information that I would want you to know would be in the on the audio. So obviously working in the ER is different from working in other areas in a hospital, right? And it wouldn't be called emergency nursing unless there was something unique about it, right? So the next couple of slides will address what some of those unique features are in terms of emergency nursing. So right off the bat, you know that when you come to the ER, what is it? It's very crowded, it's a small space, and there really isn't that much privacy in the emergency room, right? They have the little bit of curtains that they have, but pretty much when somebody's being interviewed, you can pretty much hear the whole story, right? So that's just a problem that happens in the ER, right? So that's just something you have to be aware of when you're speaking, that you're not using a loud voice. So I can't remember if any of you have worked in the ER, but these are some of the things that you want to think about. The issue of consent, right? So sometimes people come to the ER because it is an emergency. Maybe they've been in a car accident, and maybe their baby swallowed a bottle of aspirin, and the baby now is comatose, right? In that situation, the mother would bring the baby, and obviously the mom can give consent. But what if somebody was just found on the street, right, and in a coma or something, unresponsive? They bring the patient to the ER, and there's no one there to give consent. So in those cases, the hospital will give consent in the interest of the patient, because the patient can't make the consent at the time, so they'll make an executive decision to do that, and that's pretty true across the board, just trying to save the patient's lives. So just know that you may encounter issues of consent and privacy when you're working in the ER. So usually they need a lot of invasive types of procedures, right? So they may need like an angiography or lumbar puncture, right? And so somebody has to make those decisions, and if they can't make the decisions, then the hospital will. You are at risk as a healthcare worker working in the ER to other viruses or even bacteria, because you have no idea what's coming in there, right? Maybe somebody's coming in, with hepatitis C or B or something. You may not even know that, right? Maybe they're HIV positive, they have TB. You never know until you've done the tests. So it's after the fact that you're going to know that the patient has TB even. Most recently with the COVID-19, a lot of healthcare workers were affected, right? And they didn't know that the patient had come in with COVID-19 until the test came back, or until they were feeling ill. So basically, you as a nurse, you're at risk to a lot of communicable diseases, as well as all the other patients that are also in the ER, right? So you can get these diseases through blood, respiratory droplets, or other fluids. So you have to really adhere to strict precautions for minimizing exposure. So you do what you can, and you basically assume that everybody that's coming in the ER has something. So at the very least, you're going to be using standard precautions from the time they come in. A lot of people that come into the ER, obviously they're stressed, they're depressed, they're angry, maybe their baby's dying, they're traumatized, they're in the emergency room and this situation is not working out, or maybe somebody's coding. So sometimes family members, have the potential to become really angry. So there's a lot of violence that can happen in some emergency rooms. That's why you see that there's police officers around, right? Patients are angry, they're scared. Maybe somebody has been hit in a car accident, there's a deadly disease. Sometimes they have prisoners that are coming up and they're in handcuffs. And I've had the pleasure of taking care of prisoners. I think that was at Lincoln Hospital. And my experience with them was always positive, actually. They always just seemed to be happy not to be in, whatever prison they were coming from. So they were actually some of my best patients. So anyway, so the staff member is going to encounter a lot of issues. So maybe their patients are having effects of substance abuse, injury, or other emergencies. So it's just a really, really volatile situation. All right. So safety is always the first priority. So you want to make sure that you are safe, right? And if you feel unsafe, then you want to make sure you get help and that somebody else is there supporting you. All right. Still, you try to provide holistic nursing care, and their family members, they're overwhelmed by anxiety. The patient is maybe overwhelmed by anxiety because it's a crisis situation at this point. So you want to make sure that you do your best to kind of minimize how they may be feeling. So what are you going to do? The patient is probably going to go through a whole bunch of stages of grief even. So maybe they're anxious, they have denial, remorse, guilt, anger, grief, and reconciliation. All of those things may happen in your patient. So you just want to be aware of that. Making sure that you're aware of the family psychological function, you're evaluating the emotional expression, degree of anxiety, and cognitive functioning. So you're providing holistic care. All right, so emergency management traditionally, so this is key word is traditionally, refers to urgent and critical care needs. So way back when, when somebody's showing up in the ER, we used to think was primarily for urgent and critical care needs. But now, a lot of people have been coming there for non-urgent problems. So it's kind of now, well, that's changing again, but the emergency management has broadened to include the concept that an emergency is whatever the patient or family considers it to be. So it used to be only for urgent and critical care needs, but at some point, patients that were coming in did not necessarily have urgent needs, but then they said, okay, well, it's going to include whatever the patient deems to be an emergency. However, because of insurance coverages, all of that, now we have what are known as urgent care centers. So unless you are literally dying, some insurances will not cover you if you show up in the ER. They would rather you go to an urgent care center and get treatment. So maybe you're just feeling dehydrated. They would rather you just go to that place, get treated, versus you go to the emergency room because they would charge you like a hefty amount of money. As an ER nurse, you obviously have special training, education, expertise, and experience in working in crisis situations. So nursing interventions are accomplished interdependently in consultation under the direction of a physician or nurse practitioner. And obviously, ER staff works as a team. That goes without saying. So priority emergency measures for all patients. Okay. So what are we doing here? So safety is always the first priority. So you're going to keep seeing that word over and over again. Pre-planning to ensure security and a safe environment. So this is something that the administration should kind of consider from the very beginning. You should not be walking into any ER and feeling, not safe, right? The administration should have taken measures to make sure there's a security guard in there, making sure you have the right PPE, making sure there's enough staff, all of those things, right? You need to be monitoring patient and family members with their response to stress, because you want to make sure that they're not going to become violent. And that's why usually in the ER you find that all the doctors you need are right there. They won't be anywhere else but right in the ER. So if you need them, you should be able to get them pretty quickly. Assessment of patient and family psychological function. Patient and family focused interventions. So all of that has to do with relieving anxiety and providing a sense of security, allowing family to stay with the patient, if possible, to alleviate anxiety. So keyword is if it's possible. If you need to intubate the patient, but it's a really hard intubation, it's okay if you ask the family members to wait outside. Although I think we talked about this before, a lot of family members are less likely to sue if a patient goes into a cardiac arrest and they are able to stay with their family member and watch what all the nurses and doctors are trying to do in terms of trying to revive the patient or trying to revive their family member. So if they can stay in the room and it's a well-organized code, they might not sue. They're less likely to sue because they're going to see that you worked really hard. Unfortunately, that works the other way too. If it's a messy code, nobody knows what they're doing, then obviously they're going to sue you. But anyway, so the nurse always has the right to say, you know what, do you mind stepping outside while we do XYZ procedure? All right, you're providing explanations and information, and obviously additional interventions are provided depending on the stage of the crises. So the word triage, right, means to sort, and I'm sure some of you have heard of this term already. Um, so what is happening here? So you basically triage sorts patients by hierarchy based on the severity of the health problems and the immediacy with which these problems must be treated. So the triage nurse collects data and classifies the illnesses and injuries to ensure that the patients most in need of care do not needlessly wait. Um, so the big difference though here is that ED triage differs from disaster triage in that patients who are the most critically ill receive the most resources regardless of potential outcome. So triage in the emergency department when there's no mass casualty disaster, there's no Hurricane Sandy, there is no terrorist attack, and you're not getting a whole bunch of patients showing up. In that regular normal circumstances, like let's say 6 months ago when nothing much was going on, when the patients would show up in the emergency department, you would take care of the most critically ill patient, regardless of whether or not that patient would make it or not. So if a patient shows up and they're comatose, they have a piece of big metal in their back because they were in a car accident, and you know that in order to treat this patient you have to ventilate them, you have to take them to the OR, you have to give them all these highly specialized medications, you have to operate on them. All of that will be taking up resources, right? And they may or they may not make it. It doesn't matter. You are going to see that patient first. So in a disaster situation like what we're going through now, because it could kind of be considered a disaster. If you have that same patient I just finished talking about, and then you have another patient that shows up, and maybe they also have COVID, but maybe their symptoms are a little bit milder, and yes, maybe they need to go on a vent too, but maybe they have a pneumothorax or something, and the only thing you have to do is put them on a vent, and maybe on top of the pneumothorax, you have to put them on a chest tube, and then you know that they're going to be okay, right? So maybe the only issue they had was that they weren't breathing properly, so they just need a event. Well, in a disaster situation where resources are scarce, you are going to take care of the patient that's most likely to survive. Okay, so that's why you triage them, you put them into categories. So if anybody is going to be left to die, then somebody has to decide that, and some patients will definitely be left to die. So that's what you just need to know, is that in ED triage, it differs from disaster triage. The word triage is still being used. So don't get confused by the fact that, yes, there is a disaster. And yes, these patients are showing up in the emergency department. And yes, they have to be triaged. But now there's a disaster going on. So it's not a normal triage, it's a disaster triage. Okay, so then you have to categorize your patients, and you have to take care of the patients in a disaster situation that are most likely to survive. All right. So another example might be a patient shows up, their GCS is 4, they have multiple trauma, and they're bleeding out, right? And this is in a disaster situation. And then versus the same example I gave you before, where you have another patient just has a pneumothorax, and all they need is a chest tube. Or if it's in a disaster situation and you have somebody whose GCS is 4, they have multiple trauma, and they're bleeding, you are going to essentially triage the GCS of 4 in a disaster situation as category black or number 4. So that means you're not going to get to them right away. You are going to treat the other patient with a pneumothorax and that has a chest tube need, because that's easier to manage right away. So just please know that. But in the normal circumstances, if I show up, my GCS is 4, everybody's going to rush to me and try to take care of me. So there is a systematic approach utilized to treat health priorities. It's known as the primary survey, secondary survey approach. So this stuff you guys are already familiar with. I'm not going to spend too much time on this, but essentially you're doing your ABCs, and you're also checking for whether or not there's any disability. You're determining the neurologic disability using the GCS. How much can this patient do for themselves, right? And E is for exposure. You're addressing the patient carefully to identify areas of injury. All right. So AOA, establishing a patent AOA, breathing, employ resuscitation measures if needed, circulation, evaluate and restore cardiac output, disability, see what their GCS score is, and E is for exposure. See how much injury, how much of their body is burnt, even if that's the situation. Um, so you're also doing what is considered a secondary survey. So you're continuing what you started in the primary survey. So now you're doing a complete health history, including history of current event. You're doing a head-to-toe assessment. You're doing diagnostic and laboratory testing. You're putting in your monitoring devices. So whether that's your arterial lines, urinary catheters, your splinting, any suspected fractures, wound care, all of this. So this is just your primary surveys that's been started in the emergency department, and now this is secondary service. You're doing more things. So you're adding up to some of this. So for this particular slide, we've talked about some of this already in previous lectures. And you know that if there's an emergency going on, there's certain things you have to do. So depending on how your patient presents, then you know that there's an emergency management that's required. So if your patient's showing up, let's say with a hemorrhage, what are you going to do? If your patient's showing up with multiple trauma, let's say they have fractures, what is the emergency treatment? If your patient is showing up with burns and carbon monoxide poisoning, what does treatment look like? I mean, in general, you know it's all about AOA. You know it's about controlling bleeding if that's going on. You know it's about preventing or treating hypovolemia if that's going on. You're evaluating for any head injuries always. You're evaluating for other injuries. You're exposing the skin and trying to see, how bad the injury is, if it's something like a burn. And you're just always performing like a very thorough ongoing examination or neurological examinations as well. You're splinting fractures. You're reassessing. You're doing your neurovascular checks, all of that. So we've kind of encountered emergency care under different conditions. So don't overthink any of this. All right. So this is a picture of a disaster management plan and just all the different components that have to go into making sure that we have a disaster management plan. So these are some of the main components under disaster management. So things like preparedness. So every institution has to have some type of disaster management plan in effect. What is the emergency plan? How many times do they practice the emergency plan? Who does what? Like every institution must have some type of plan. And the response, like what is it that is supposed to basically go out in the event of a disaster? And then after the disaster is finished, then what types of things do we need to have in place? Like, are we going to need things like temporary housing? Are we going to need, I don't know, what is it saying? Claims processing and grants, right? Long-term medical care and counseling. So, I mean, like right now with COVID-19, this is considered a disaster for some. People are out of work. And so, like, what measures have we put in to protect people from getting, money for the next, I don't know how long, right? And then we try to basically figure out, because then you have to assess everything that's happened post-disaster, any activities that can reduce the effects of disaster. So like, what are we going to learn after COVID-19 is done? Like once this whole thing is said and done, we've done studies, we've looked at it, what have we learned, and how can we use any of that information to better prepare next time? So a really good plan will look at all of this ahead of time before it happens. And different plans are going to be different for other places. So maybe for New York City, for whatever reason, I'm making this up, but let's say we suffer a lot from, making this up, it's a bad example, but we suffer a lot from maybe, oh, well, a good example maybe would be like we get the terrorist attacks a lot. I don't know if that's a good example, but let's say we get attacked a lot by terrorism. And so maybe for our purposes, we've identified that there's a particular agent that they use on us and they try to use to kill us. And so therefore now we need a particular medication in our emergency cart to make sure it's always there so that if that ever happens, we have that medication. Versus maybe somebody lives in Iowa and maybe for them, their biggest disaster thing is that during a certain time of the year, maybe there's a flood or something, right? So for them, their disaster management plan might look slightly different, right? So the disaster management plan has to include things like medications. It has to include things like environment, like what are the resources in my environment, what does the response team need to be. Maybe in some places it's the response team is the fact that maybe horses are the way that people are going to get to other parts of the country to help other people because they're stuck somewhere. I don't know. So in New York City, maybe our train system gets bombed or something crazy like that. So now what are we going to do? So it's just anyways, what I'm trying to say is that the disaster plan has to be specific for each location, and it's not going to be the same across the board. All right, so there's a whole bunch of different ways that we figured out that we can basically kill ourselves. And so apparently this whole concept of using weapons of mass destruction goes way, way back. Apparently goes as far back as the 6th century BCE. And now, though, because of the availability of destructive technology, everything is basically like right at our doorstep. So terrorism, by definition, involves using violence to create feelings of fear. So you've been given a couple of examples. All right, and then the U.S. Department of Homeland Security for sure was created after the attacks of September 11, 2001. So these are some things that you kind of want to remember. You don't want to forget these dates because they are important, especially like during JCAHO time. Sometimes you may get questions pertaining to when the U.S. Department of Homeland Security was created. Because they want to know how knowledgeable you are about disaster management types of things. So every facility, in particular receiving preparedness funds, must have a plan that adheres to guidelines devised by the National Incident Management System. So some of these terminologies I would like you to remember, which is directed by the Federal Management Agency, which is FEMA. So the NIMS guidelines is effective for terrorist events as well as any disaster situation, including natural disasters as well. And so warfare, terrorism, and natural disasters are just some of the reasons nurses must plan for mass casualties. Okay. You've got resources at the federal, state, and local levels to assist in the management of mass casualty incidents. So mass casualty incidents, the MCIs, disasters and emergencies. And a mass casualty incident is defined as any incident that causes a large numbers of casualties to the extent that necessary resources become too scarce. So this right here is describing COVID-19. So we've basically had a mass casualty incident that's caused large numbers of casualties to the extent that necessary resources become too scarce, right? So when resources to care for casualties become scarce, so this is key, the greatest good, this is an important quotation to remember, the greatest good for the greatest number of patients becomes the mode of operation. So a disaster response strategy cannot succeed without appropriate physical assets and staff trained and prepared to carry out the plan. Assets such as increased security, stockpiles of equipment and medications, and planning, drills, and training are essential. So all of this is true. All right. So here you're just being given some federal agencies examples. You have your U.S. Department of Health and Human Services, Department of Justice, Department of Defense, and Department of Homeland Security. So under different presidents, some of these work better than they do under other presidents, and that's all I'm going to say. The state and local response agencies may be branches of the federal agencies. So at the local level, again, you're getting things like the CDC and the FBI, the Red Cross, the Poison Control Centers, and local volunteer organizations. So for sure, I know pretty soon you guys will be bombarded by letters from Como as well the minute you graduate, asking you to basically either volunteer or to ask you guys to kind of help out as soon as you can with COVID-19. All right, so for each facility, right, so this is what this particular slide is talking about. For each facility, they must have what is known as an incident command system. So this is a federally mandated command structure that basically coordinates personnel, facilities, equipment, and communication in any emergency situation. All right, so that's an important one to remember, ICS. So you must have an incident command system. So when Hurricane Sandy was going on, this would all have been figured out already. They would know, who the personnel was, or know what, they would know exactly know what their equipment capabilities were. They would find out like who's going to be the person communicating with their TV. So remember, Hurricane Sandy really affected, I think, Bellevue as well as I forget the other hospitals downtown, but there was a lot of flooding. Might have been NYU too, I think. So all of that there has to be like a command center, a command system that basically guides how all of this is going to work. So it's a center of operations for organization, planning, and transport of patients in the event of a specific local MCI. So successful incident management requires equipment compatibility, effective communication, adequate distribution of resources, and clear differentiation of members' roles. So this last part of the last bullet here, clear differentiation of members' roles. Everybody needs to know what their particular role is. There can be no confusion, right? So ahead of time, they also would have identified who is going to be doing what, who's talking to the media, who's directing which nurses are going to be doing what, who's making the call to say, okay, I need 10 nurses on this floor versus I need 2 nurses on that floor. Like all of that needs to be identified. During the disaster is not when you're trying to figure all of that out. Okay. And then the hospital incident command system is a modification of the ICS, and this is used by hospitals and law enforcement agencies. So you have what is known as a hospital incident command system commander, the hospital incident command system incident commander. So this is a hospital emergency preparedness coordinator who oversees and coordinates all efforts surrounding the event. So in each hospital, so the key word here is if it starts with an H, it's in a hospital setting. Know that there's going to be an incident commander. So that's the person who's overseeing and coordinating all efforts surrounding the event. And then there's going to be a team, right, that's built around this commander. So it's going to include like the safety officers or public information officers, liaison officers, operation chief, logistics chief, planning chief, and finance chief. All of these people will make up a team, and everybody has a specific responsibility. So now we're talking specifically about the hospital situation here. Okay. So this is also key. So each healthcare facility are required by the Joint Commission to create a plan for emergency. And I'm sure you guys, actually, when we do our orientation to the different facilities, we talk about the EOP, right? So each healthcare facility is required by the Joint Commission to create a plan for emergency preparedness, and they have to practice this plan twice a year. This is always a question in our orientation questions when we're doing when we're going to clinicals, right? I'm sure you've seen this before. So what are the essential components of the plan? Well, there has to be an activation response, an internal and external communication plan, a plan for coordinated patient care, security plans, identification of external resources, a plan for people management and traffic flow. So like HOMO right now is trying to build up external resources by identifying, okay, who are my nurses that are retired? Who are my nurses that are soon graduating? I want to know what my resources are in case my numbers go up, and I can, pull from those people, and ask them to come in and help me. Right. Essential components of the plan. So it's a data management strategy is included. Demobilization response. So if the emergency is done, you want to demobilize. You want to stop the emergency response because you don't want to waste any more resources. So resources should not be unnecessarily exhausted. You must deactivate the response when necessary and identify the key person who's going to do that. So somebody's going to be watching everything, right? And that person is going to say, hey, you know what, we're good now. We don't need to be, sending any more medications or begging for more vents from the president or whatever it is. We're pretty good. There has to be an after action response. You have to have a plan for practice drills. You have to anticipate your resources, like I mentioned. So you're going to look at each environment, each situation, and see what your anticipated resources are. You must have mass casualty incident planning, and everybody must be educated in all of the above. So they're going to have in services about the EOP, right? And everybody's going to know who's the HICS commander, like who's that person, like all of that is information that every staff member needs to be aware of. All right. So triage we've discussed already. So in non-disaster situations, healthcare workers assign the highest priority and allocate most resources to the most critically ill patients. So keyword is in non-disaster situations. And then in disaster situations with large numbers of casualties, decisions are based on the likelihood of survival and the consumption of resources. So we have a special color coded tagging system, right, which is used during the mass casualty incident. And there are different ways that they can triage patients, but every nurse has to be aware of the triage system in their hospital. So some of them are using the colors, some of them are using the numbers. It doesn't matter what they're using. You want to make sure you know what it is in your institution. All right, so this is just one example, right? So 1 and red means that we're going to deal with these patients right away. And 4 and black, they can also use the word under 1 is immediate, 1 or red, or they can use expectorant, 4 or black. So that's what that means. So if they categorize you as 2, that means they can wait a little bit, it's delayed. And it's color coded as yellow. If they give you 3, it's minimal is how they're defining it, and the color is green. But like I said, for your purposes, look at your chart and focus on categories 1 versus 4. Like see if there's a difference between those categories. And I'm looking at it right now. So it's on page 2197. So for instance, under immediate, your injuries are life-threatening but survival with minimal intervention. All right. So this is your triage categories during a mass casualty event. So remember the key word was always we want to have minimal interventions. We don't want to be having to do surgery. We don't want to have to, using too many resources, right? So under immediate, injuries are life-threatening but survival with minimal interventions. Individuals in this group can progress rapidly, though, to expectant if treatment is delayed. So that's the whole problem. We want to keep them from getting worse. So your examples here are like a sucking chest wound, airway obstruction, secondary to mechanical cause, shock, hemothorax, tension pneumothorax, asphyxia, unstable chest and abdominal wounds, incomplete amputations, open fractures of long bones, etc. So these are things that we can treat pretty quickly, and hopefully you're good to go. In expectant or category 4, priority 4 or black. So for this one, injuries are extensive and chances of survival are unlikely, even with definitive care. Persons in this group should be separated from other casualties, but not abandoned. So you don't want to keep them near the other patients, because then they're going to guess the other patients may be affected by seeing them. Also, comfort measures should be provided when possible. So comfort. Patients who are unresponsive with penetrating head wounds. So these are the examples. Patients with who are unresponsive with penetrating head wounds, high spinal cord injuries, wounds involving multiple anatomic sites and organs, second, third degree burns in excess of 60% of the body surface area, etc. All right, so those are some of your examples, but you want to just look at that chart for me. All right, so managing internal problems. So for triage, or even if for your home, actually, forget about the mass casualty event. The Red Cross has like a basic survival kit or a guide that each facility must determine its supply list and determine the top 10 critical medications used during normal day-to-day operations, and then anticipate which other medications may be required in a disaster or an MCI. So Red Cross has provided some guidelines in terms of which meds we need the most, let's say in a New York City hospital versus a hospital in Iowa, like I said before. But this kit you can also get for your house as well. And it's not going to have obviously some of the meds that you would see in the ER, but it has basic things like, I don't know, antibiotics or something, or bandages in there. Communicating with the media and family members, ethical conflicts. So let's say you are at work. I've talked about communication already, that there should be one person who's communicating with the media and family. The ethical conflicts are like if you are, let's say right now during COVID, you are a nurse and your brother shows up in the ER, and he is blue and black, and like he's categorized as 4, right? Which means, you know what it means, that they're going to put him aside and basically let him die. And you are the nurse that, gets to see this happening. So what are you going to do? Are you going to try to save your brother, or are you going to abide by, the triage during a mass casualty incident, right? So this is really, really tough, and it happens all the time. The other ethical conflicts are, that there's not enough resources, but maybe it's your colleague that's in the other bed, and you know that their triage is category 4, but there's another young man in the other bed who needs whatever medication you have. What are you going to do? Are you going to save your colleague, or are you going to save the stranger in the other bed? Yeah, so all of this has to be addressed. I highly doubt that anybody would sue you or really be evil in terms of trying to get your license away if you, let's say, decided to save your brother than another patient. Like, I think people would understand that, but we do, I don't know. I mean, I really don't know if somebody would bring charges against you for that. But you never know, because maybe the other person that died was another rich person's son, and they knew what happened. You know what I mean? Like, it can get really, really complicated. If it's just some bum off the street that nobody cared about, maybe no one would notice. But maybe it was a rich person's son, and you ignored that person because you wanted to save your brother. So now what are you going to do? I have no idea. And your brother was, category 4, but the other person wasn't. Anyway, so it's a lot of things that you have to consider. So managing behavior issues also, because it's a very stressful time, emotions are high. So people can even become very violent, actually, or they may behave in ways that you never thought they would. There is what is known as a critical incident stress management, CISM, and this is incredibly important, where all of the staff have to basically debrief. You talk to them, you let them vent, you find out what their issues are. I'm pretty sure you guys have heard of that doctor at Columbia Presbyterian who was dealing with a whole bunch of patients who were dying from COVID-19, and she committed suicide. Like, I mean, she saw such horrible things that she just couldn't take it, and she went and she killed herself. And this was a doctor with like an exemplary, like amazing record, and that was absolutely devastating. I saw the article in the paper the other day. Yeah, so they have to make sure that they're dealing with all the stress during these times. So the role of the nurse during a disaster varies. Keyword is it varies. So nurses may be asked to perform duties outside the areas of expertise and may take on responsibilities normally held by physicians or advanced practice nurses. So a critical care nurse may intubate a patient or even insert a chest tube. A nurse may perform wound debridement or suturing. A nurse may serve as a triage officer. All right. So although the exact role of a nurse in disaster management depends on the specific needs of the facility at that time, it should be clear which nurse, and this is a key word, it should be clear which nurse or physician is in charge of a given patient care area and which procedures each individual nurse may or may not perform. So if you were working on a med-surg floor, and you have a lot of experience with splinting patients, or maybe, yeah, even like if somebody shows up with a fracture, you know how to put that bone back in. So they know that if there's those types of injuries, they're going to make you the person that does those types of things. You would not be the nurse, let's say, that now there's a disaster situation, all of a sudden you say, oh, you know what, I want to intubate. No, because you haven't had experience in that. So it has to be clear from the very beginning which nurses have which experience, which expertise, so that in the disaster situation, each nurse is able to basically work outside their scope of practice. And that's fine, only during a disaster situation. But you can't just start suturing patients when you've never even sutured, right? So maybe somebody who works in the ER, has seen a lot of those and they have some experience. I don't know how they got the experience, but let's say they have some, and then now they're able to start suturing patients. So all of that, but you have to agree ahead of time on who's going to do it. Okay. Preparedness and response personnel, so PPE. So purpose is to shield the healthcare provider from chemical, physical, biological, and radiological hazards that may exist when caring for contaminated patients. So there's different levels of PPE. So even for this one, guys, I would probably just want you to know what level A looks like versus what level D looks like. So for your purposes, know that level A is for the highest level of respiratory, skin, eye, and mucous membrane protection. So this is when we're having like Ebola patients for sure, or even like right now with COVID patients. Like how do we have to gown up and gear up and just everything we have to put on versus our typical uniform that we may be wearing at work. So just know the differences, at least between A and D. So this is what that may look like, right? So see level A. I don't think we're looking like this for COVID, but I know we looked like this for Ebola for sure. All right, so I'll stop this one here and I'll continue the rest of the slides because it's so much information.